Welcome to Nursing 542, Module 11. This week's module addresses the management of renal and urological conditions in the primary care setting. A urinary tract infection is considered uncomplicated in otherwise healthy, non-pregnant females. A short 3-day course of antibiotics has been found to be effective for uncomplicated urinary tract infections while minimizing medication side effects. UTIs are considered complicated if there are comorbidities such as diabetes, pregnancy, or known functional or structural abnormalities of the urinary tract, or in men. There is some disagreement over whether all UTIs in men are considered complicated or not, but they do require a longer course of treatment, so I put them in the complicated category. Complicated UTIs require a 7 to 14-day course of treatment depending upon the medication of choice. Lower urinary tract infections, complications from those can progress on to pyelonephritis, urosepsis, shock, and even death. Those at higher risk of complications include diabetes, patients treating autoimmune disorders with steroids or other immunocompromising medications or treatments, such as rheumatoid arthritis or cancer. They're at greater risk. And pregnant women are at the risk of complication for pregnant women could be premature delivery or miscarriage. So, not to be taken lightly. Patient education is listed here. In some patients, additional workup or evaluation may be warranted. For example, in a male diabetic, you do a culture and sensitivity. In an older woman with recurrent urinary tract infection diagnoses and no relief of symptoms, you'd want to do a pelvic exam. In a female diabetic, you'd want to do a culture and sensitivity before and after treatment and treat with a longer course of antibiotics, 7 days, and refer to a nephrologist for recurrent urinary tract infection. Goals of treatment in upper urinary tract infection is to avoid permanent kidney damage and relieve symptoms. Pyelonephritis, acute, you can treat outpatient if they don't have, if they're not acutely ill with nausea and vomiting and don't have any signs of sepsis, but you'd treat for 7 to 14 days. In more severe cases, and quite frequently, the patients are hospitalized and treated with IV antibiotics. If they have chronic pyelonephritis, you want to refer them to a nephrologist. Moving on to urinary incontinence management. Management of urinary incontinence varies, obviously, depending upon what the underlying cause is. Patient education regarding the underlying cause and treatment are important. General nutrition and exercise are also important aspects of patient education. Addressing the psychosocial impacts of urinary incontinence are essential. Be sure to screen and treat accordingly for depression, because some studies have shown some correlation there. For many of the different types, several, I guess a couple of them anyway, note the Kegel exercises are a form of treatment, so you'll want to be able to educate your patient on how to perform Kegel exercises. Moving on to BPH, medications to be avoided that can enhance BPH symptoms include decongestants, other sympathomimetics, and anticholinergics. Sedatives, over-the-counter cold and allergy medications, and sleeping pills fall into these categories. Common side effects with the alpha-adrenergic blockers is hypotension, so you should advise your patient to take the medication at bedtime if at all possible. Side effects with the finasteride include decreased libido, ejaculatory dysfunction, and impotence, so you won't have a lot of people begging for that medication. Long-term treatment with finasteride, in addition, increases the patient's risk of high-grade prostate cancer. So there's a reason I've never prescribed that medication, but if you're having trouble with urinating, you got to do something to get that taken care of. A lot of patients will utilize herbal treatments, and they need to be educated regarding the lack of evidence supporting use of herbal treatments for BPH. Patients should also be advised to report any hematuria, urinary tract infection symptoms, or increased urinary retention. Urology referrals is appropriate for a patient with comorbidities, recurrent infections, or hematuria, or if symptoms are severe enough to warrant consideration of a surgical treatment, or if they have acute prostatitis, or if cancer is suspected. So the saw palmetto that you hear a lot about, it's not been shown to be any more effective than placebo. And the surgical treatments, I know in the past everybody, I don't know, you guys are all younger, so maybe you haven't, but it used to always be the TURP that you heard about for BPH or prostate cancer, and the outcomes, a lot of significant side effects. And so now they're developing a lot of newer surgical procedures and treatments that statistically don't have as significant side effects. Prostatitis, urine culture upon completion of antibiotic therapy is recommended if you've treated for it. Patients with symptoms of BPH, infection resistant to treatment, or chronic pelvic pain syndrome, non-bacterial prostatitis, should be referred to urology. I personally would seek a urology consult with any case of prostatitis to confirm that malignancy wasn't being missed, but that's just me. Patients need to be educated on the need to complete the entire course of antibiotics. Acute bacterial prostatitis patients should also be advised to utilize condoms to prevent reinfection during sex and to avoid anal intercourse. Alcohol and caffeine are known bladder irritants and should be avoided. For the chronic bacterial prostatitis, you'll note 6 to 12 week, and I've seen it even longer, course of antibiotics. Prostate cancer, treatment for prostate cancer is provided by a team consisting of urologist, radiation oncologist, and primary care provider. Your role in primary care will be to support the patient throughout the process, advocate for treatment options to be explained fully to the patient, including potential side effects of each, and encourage the patient to complete all follow-up evaluations as recommended by the specialists. Bladder cancer treatment. Urology consult will be appropriate for all bladder cancer patients. Oncology, radiation, ostomy nurse, and hospice referrals may also be appropriate depending upon the stage of the disease. Primary care role again will be to provide support throughout the course of treatment, address any comorbidities while maintaining close communication with the specialists that are treating the patient, and having discussions regarding advanced care directives and end-of-life discussions as appropriate. Renal cancer treatment. Again, treatment is provided by a team consisting of urologist, oncologist / radiation oncologist. Primary care role, again, will be support of patient and family throughout the process, discussing end-of-life wishes, advanced directives, and referring to hospice as appropriate. For patients with localized disease, counseling regarding importance of follow-up screenings, nutrition, and exercise will be necessary. Frequently, renal cancer treatment consists of a nephrectomy, and usually that's a cure if it was localized, but if not, it's sometimes done for palliative purposes as well. For acute kidney treatment, the goals of treatment are always to identify and treat the underlying cause if it's reversible, and also to treat any life-threatening complications that occur. Initial treatment is assessment of the volume status of a patient and electrolytes. I want to assess for fluid overload, metabolic acidosis, hyperkalemia, which can result in sudden cardiac death, hypocalcemia, and hyperphosphatemia. So you want to start assessing for that. Treatment includes correction of electrolyte and acid-base imbalances, IV calcium gluconate, insulin, albuterol, dextrose, or Kxalate may be used to treat hyperkalemia. Calcium acetate or carbonate can be used to treat hyperphosphatemia. RBC transfusions may also be given. As a primary care provider, your role will be to recognize the acute kidney injury and refer the patient for acute care. After their hospitalization, you will want to ensure that the patient follow up with a nephrologist for close monitoring. A key point for primary care providers is that referral to a nephrologist should be made whenever you note a decline in GFR. Avoidance of medications known to be nephrotoxic is vital to preventing acute kidney injury. In addition to educating patients about the medications to avoid, patient education regarding maintaining optimal blood pressure, weight, smoking cessation, low sodium diet, and strict glycemic control are important to address in the primary care setting. For kidney stones, treatment depends upon the size and location. Stones that are smaller than 4 millimeters usually can be passed as outpatients. Stones 4 to 5 millimeters have a 50% chance of passing, and beyond 5 millimeters they require lithotripsy by a urologist where the stone's broken up. Your role as a primary care provider will be to monitor for complications and manage pain in patients who are treating as outpatients. For patients requiring urology referral, your role will be to educate the patient regarding dietary restrictions, adequate fluid intake, and the possibility of recurrence. A 24-hour urine collection is recommended 6 months post-stone passage in all patients. Chronic kidney disease. The goals of treatment are to slow the progression of the disease and maximize the quality of life for your patient. In primary care, as indicated in last week's lecture, the most important aspect is identifying the chronic kidney disease before it becomes clinically apparent. You will want to maintain as strict control as possible of blood sugars and hypertension, but remember, it's important to remember that the systolic pressure needs to be maintained at 110 or above in order to maintain adequate renal perfusion. Referral to a nutritionist is often appropriate, as patients will need to maintain low protein, low sodium, low phosphate, low potassium diet. There's a fine line between, when you're treating with diuretics, between maintaining adequate volume but treating edema. So that's going to be a difficult line you'll have to walk with a chronic kidney patient. Close communication with the urologist as you monitor for any change in condition and treat comorbidities is absolutely key. You want to ensure that the patient receives holistic treatment that addresses any psychosocial, social, and spiritual needs. Ultimately, as a primary care provider, you will have discussions with your patients regarding dialysis, transplant, and end-of-life options and preferences. Erectile dysfunction treatment. You need to be very cognizant of the potential side effects of any pharmacological therapy provided for ED. I think these are way too frequently written for without any thought process. The PDE5 inhibitors such as Viagra are contraindicated for patients with severe heart disease or those who use nitrates. So a potential risk with testosterone replacement, which is gaining popularity, include cancer. Providing the patient with comprehensive education on the pros, cons, and potential side effects of all medications or changes in medications is imperative. Referral to urologists specializing in ED for non-pharm treatment options, and referral for counseling or support group may be appropriate as well. Again, I know we've covered a lot of information this week. It seems like I say that every week, doesn't it? Please post any questions under the course communication tab so we can all benefit from the discussion. Thank you and have a good week.